Hello and welcome to Module 2 of the LNET curriculum, where we're talking about pain management throughout palliative hospice and end-of-life care. So this is going to be a 3-video series, just like the introduction was, and we're going to talk about what pain is, how to relieve pain, barriers to pain control, and then describe pharmacological and non-pharmacological therapies to relieve pain, as well as discussing the role of the nurse involved with pain assessment and management of pain at the end of life. In Unit 1, or into the introduction, we talked about the first domain of the NCP guidelines in palliative and end-of-life care. So now we're going to talk about Domain 2, physical aspects of care. It's important to understand what pain is, and that pain is really, it's a multidimensional experience for patients, and so it really requires a multi-dimensional approach, both pharmacological and non-pharmacological therapies. It's been documented that about 40% of hospitalized patients experience uncontrolled pain within a few days of the end of life. So pain management is very complex and it's very difficult, and it's not well controlled at the end of life. So that's why we're going to spend so much time talking about pain management. So pain, it's that sensory experience, but it's also an emotional experience. And so with that, there are the physical aspects and emotional aspects. So things like anxiety can increase pain. Anxiety can increase nausea. That's a different type of symptom. But remember that there is that emotional component to pain. So there is nociceptive pain and neuropathic pain. And pain and nociceptive pain, they're different phenomena. So pain cannot be inferred solely from activity on the sensory neurons, which is why it can be so complex to treat. And throughout individuals' lives, they learn different concepts of pain. Different experiences teach people different things about pain. So that's why pain is what the patient says it is. And it can be biopsychosocial, it can be spiritual, it can be existential. So it's important to remember pain is what the patient says it is. It is emotional as well as physical, and then there is typically meaning applied to the pain. Perhaps some of the most well-known pain are pain and cancer, so cancer pain. Approximately 80% of patients with advanced cancer have moderate to severe pain and often experience multiple sites of pain. So it's a very complex issue. There's a lot of challenges to managing pain. So patients may believe that pain is normal, or it could be a failure of the healthcare team to see the pain through high quality assessment and management. Or maybe the healthcare team doesn't see pain, managing pain, as a priority as they're focusing on the disease pathology. Patients may fear that pain means that their cancer is progressing or recurring, and they may be afraid to report it to their provider. They don't want to be seen as weak or drug-seeking, or even distract the provider from managing their condition. One of the other barriers that is really frustrating, and we can do something as nurses, but patients may believe that everything is already being done to alleviate the pain. And that's not necessarily the case. So it's very important to assess the pain so that we can ensure that we are managing the pain as best we can. Pain has a lot of implications on the body and on well-being. So pain is associated with depression, especially in patients with heart failure. But inadequate pain relief has been documented to hasten death. So think about that. Unmanaged pain may hasten death. It's been shown in studies to do so. Pain increases physiological stress. It decreases immunity. It decreases mobility and functionality. It can increase the possibility of pneumonia or thromboembolism. And it also increases the workload of the heart and lungs. So think about pain activates the sympathetic nervous system, and the body, it really is very, very taxing on the body. So think about inadequate pain hastening death. And there are a lot of barriers to relieving pain. So some of those barriers may be inadequate knowledge on the part the healthcare professional. So inadequate assessment or management. The assessment may be inadequate due to a lack of time. Maybe the nurse doesn't have time or think about digging deeper into that pain assessment. Maybe there's fear on the part of the patient of being seen as an addict, or again, distracting the healthcare team from their primary disease pathology. And so there's also concerns about patients becoming tolerant of analgesia and fear of legal issues and exclusion of current non-pharmacologic measures. So there are a lot of barriers to pain relief. Again, which is why a lot of pain, up to 40% at the end of life, is not adequately managed in the patient. So that's again why we're talking about it, so that we can really help you as our future nurses help patients to manage their pain. There are multiple strategies to overcome challenges in pain management. Education is going to be one of the first things. You can't practice what you don't know. So again, in this course, you're learning how to do a really good pain assessment. The first part of that is being aware of the pain that the patient is experiencing and challenges to addressing that. So advocating for the increase the availability of pain management and palliative care services, using valid tools, pain screening tools, making sure that as you're monitoring your pain and assessing the pain, being sure that the whole care team is using the same scale. Where I work, we use the 1 to 10, what is your pain, and everyone uses that scale, but in some facilities, the nurses will use whatever pain scale they're comfortable with. So if a nurse is using one pain scale and then this nurse who comes on is using a different pain scale, you're not having similar assessments, even though they're both pain tools or tools to measure the pain. It's not necessarily going to be something that is adequately assessing the pain, and if you can't adequately assess the pain, you're not going to adequately manage the pain. It's also important to educate family and patients. So set realistic goals with the patients and families and inform them that most pain really can be addressed. It's not something that they have to live with. It's not inevitable. It's going to happen, but it can be managed. In managing this and providing education to the patients, it's important to provide psychosocial and spiritual support as well, because remember, pain is emotional as well as physical. And then, of course, there's always a need for continued research, so I'll put in a plug for anyone who wants to advance their education. In order to achieve adequate pain relief, it is absolutely critical to have excellent pain assessment. So in this assessment, you have your goals, and you can have your goals clearly articulated. So a lot of the goals of the patients are going to be, obviously, decrease pain and the other symptoms. A lot of times pain will cause nausea. It can cause decreased mobility, decreased functionality. So a lot of those symptoms are going to be better controlled when pain is controlled. Decreasing the distress caused by pain is important for both the patient and the family members or caregivers. Other goals include allowing the patient to have more of a sense of control. It helps to relieve caregiver burden. It helps to strengthen relationships. Between the patient and the family, between the patient and the healthcare team, and it really helps to enhance quality of life. In thinking about pain, it's important to think about suffering as well. So pain and suffering are related, but they're not synonymous. So suffering really transcends that physical, psychological, and social aspect of life. Some individuals, they may have existential distress that they believe is the reason for the pain. So maybe they think pain is a punishment from God or from past sins. I had a patient that she had metastatic ovarian cancer, and it had metastasized to the bone, and bone pain is so deep and so painful, and it's just really hard to control. But she wasn't being honest about the depth of her pain with the care team, and the daughter actually approached me and said, "My mom is in so much pain, can you please do something?" And so I started talking to the daughter or the mom, because I was like, well, she hasn't really mentioned pain to me, and she's, I know she's in pain. I know that we're giving her medication for pain, but as I started talking to her, it came out that she had had an abortion like 50 years prior, and so she thought that she deserved to feel that pain. Like she was allowing herself to feel that pain because of this existential distress she was experiencing over an aborted pregnancy decades ago. So it's important to really have that rapport with your patients so that you can identify, is there existential distress underlying this physical pain? Like, what's the emotional aspect of the pain? Because when you can start to address those existential, spiritual, psychological aspects of pain, it really improves the quality of life. And as with anything in end of life and palliative care, it's absolutely critical to have your interdisciplinary team. I do want to point out populations who are at risk for undertreatment of pain management at the end of life. Now, children and older adults, ages at either end of the spectrum, are at great risk. So, older adults, typically it's because there's cognitive impairment. They may be nonverbal, they may just not be able to communicate that pain. Children, again, can't necessarily communicate that pain. There was a study done on looking at pain management in children who had undergone open heart surgery. And of the 67 cases they reviewed, only 16% of those or 16 of those patients received opioid pain management. All others were given Tylenol to manage their pain. So think about open heart surgery. That is a cracked sternum, that is cracked ribs, that is a major thoracic procedure. And any adult going through that procedure is going to be managed with multiple opioids being compiled. They are never going to be given just Tylenol. So kids experience pain just as adults do, and it's very important to manage children's pain. Patients may deny pain. Again, it could be an existential crisis like we talked about. It could be cultural. It could be a desire to not appear drug seeking. And some patients may have a history of addictive disease. Now, does this exclude them from receiving opioid treatment at the end of life? No. Does it exclude them from receiving opioid treatment in palliative care? No, it does not. So if there is a history, it's important to know first, is this old or new? Is it current or is it past? And to just be honest and upfront with the care team. Say to the patient, you have this history. We need to manage your pain. So we're going to have a medication agreement. We're going to say, this is the plan. This is how we're going to manage the pain, and everything needs to be honest and upfront. So let's look at an example of a patient. So Lee is a 62-year-old that has just returned home after having his right shoulder pinned due to his fall. So that is a surgical procedure to repair a fracture in his right shoulder. He has a history of heart failure, emphysema, and type 2 diabetes. His home health nurse notes various sites and types of pain with pain scores. So incisional pain is a 7 out of 10. Phantom pain from left below the knee amputation secondary to diabetes is an 8 out of 10. Residual post-hepatic neuropathy from shingles is a 5 out of 10. So remember, we were talking about complex pain. And this pain, there's pains at different sites. We can't just, it's not a broken bone. Everything hurts in the bone, or everything hurts at the incision site. So he's got all these different sites, and these are also different types of pain. So he has both nociceptic and neuropathic pain. So that phantom pain, the pain, he's got neurological pain from the shingles. So this is very complex. How are you going to address this? How are you going to treat his pain? And then think about Lee's background. How is that going to shape his pain? How would you approach his pain differently if Lee was a construction worker native to Chicago versus being a first generation immigrant from China? So think about all these different complex issues of treating the pain. And how would you go about that? We'll talk about that more in class. This is not something that you're going to just be able to blurt out, I'm going to do this, this, and this. But we'll talk about the different complexities of the pain management and those different types of pain. Also, it's important to think about the role culture plays in pain. So remember, we were saying Lee, is he a construction worker from the US? Is he a recent immigrant from another country? What's going on with his? It's important to use the preferred language of the patient. If you need to get an interpreter, you need to get an interpreter. Know the way that the patient likes to learn. Do they learn through conversation? Do they learn by reading materials? Can they read? It's important. So if you have, I've seen this before, both with English speaking and non-English speaking, given pamphlets to somebody who can't read. You cannot assume that all adults are going to be able to read. Health literacy is another thing to take into consideration. Is a patient able to understand the words that you're using as you're describing these things, as you're talking about nociceptive pain or neuropathic pain? How is the patient responding to that? Fear of pain medications, again, the addiction, there's an opioid epidemic, and that's just something to be to keep in the back of your mind. But really, at the end of life in palliative and hospice care, a priority is managing the pain, and concern about addiction is a secondary concern. So that pain management is right up front. So concepts of pain and suffering, what does pain mean to this person and their culture? And using the correct labeling. So people use different words: pain versus hurt versus ache versus sore. So if someone says, oh yeah, I'm a little sore, it might be deep somatic 8 out of 10 abdominal pain, and they're just saying I'm sore or it hurts, not I'm in pain. So think about the different words that patients will use. It is a basic human right to have pain controlled. It is our ethical responsibility as nurses to ensure that we control pain. And from the statistics on this slide, you can see that as of yet, we are not doing a great job with pain control. Assessment, again, assessment is absolutely critical to adequately managing pain. There's also legal implications to consider, and then again, those ethical tenets that beneficence, non-maleficence, autonomy, and justice, these are all things to consider when treating pain in palliative hospice and end-of-life care. So this is kind of an introduction to pain at the end of life. We talked about what pain is, some barriers to pain, and the ethical responsibility of the nurse in treating pain.